Dear colleagues, let me introduce you my PhD work. My thesis title is New Insights on the Oncological and Surgical Outcomes of Colorectal Cancer Surgery. I'm Ágnes Fodor, resident in the Department of General Surgery in Szent Imre Kórház in Budapest. And my vision is that patients with colorectal cancer receive the best possible therapy, and my mission is to provide scientific evidence for this special population. To achieve these goals, I have two ongoing projects. The first one is investigating the effect of anastomotic leakage on the oncological and surgical outcomes after colorectal cancer surgery, and my second one is investigating the effect of additional intraoperative colonoscopy on the prevention of postoperative anastomotic leakage. Both of my projects will be a systematic review and meta-analysis. My first project started in September 2023. Colorectal cancer is the second leading cause of cancer death in Europe, and anastomotic leakage is one of the most feared complications following colorectal resection. The incidence of it varies between 3 and 30%, and it's associated with severe short-term morbidity and mortality. The aim of this study is to evaluate oncological and surgical outcome for patients with and without anastomotic leakage after colorectal surgery. Our clinical question is if the anastomotic leak affects the oncological outcomes after colorectal cancer surgery, and we have a population with colon and with rectal cancer after curable surgery with primary anastomosis. We compare two groups of patients with and without anastomotic leakage, and our main outcomes are overall survival, disease-free survival, local and distant recurrence. The secondary outcomes are, for example, postoperative morbidity, length of hospital stay, need of ileostomy. Our hypothesis is that anastomotic leakage is associated with worse oncological and surgical outcomes. We ran the systematic search on the 17th of November 2023 with the following search key. And we had almost 6,000 hits. And after the selection, we have 70 full text articles now. Here you can see that we already have one finished analysis of the 5-year overall survival, and we are still working on the other outcomes. On this plot, you can see the 5-year overall survival, so the preliminary results of it. We have 3 groups of the population, so colon cancer, rectal cancer, and colorectal cancer, so there is a mixed group of patients. And so the plot means if it's the hazard ratio is more than 1, that means that patients with anastomotic leakage have worse chance to survive than without. And if it's less than 1, that means that patients with anastomotic leakage have more chance to survive than the other group. The overall hazard ratio is 1.55, which means that patients with anastomotic leakage have 55% less chance to survive than the other group. These results are statistically significant and clinically relevant. And of course, there are some strengths and limitations of our study. For example, it's positive that it has a high clinical relevance, and we conduct investigation of both surgical and oncological outcomes. It's one limitation, for example, that this population is quite heterogeneous, and the studies as well. The conclusion is so that patients with colorectal cancer without anastomotic leakage have better survival compared to the anastomotic leakage group. And that means that it's very important to monitor closer these patients after curable surgery. And also important, the role of intraoperative colonoscopy in the prevention of postoperative leakage is also very important. As you can see, the progress of our first project, we are still in the phase of the data extraction, which we hope that we can finish in 2 weeks. My second project started in November 2023, and as I already mentioned, colorectal cancer is the second leading cause of death in Europe, and anastomotic leakage is a most feared complication after the surgery. There are several leak tests, however, their safety and feasibility is still debatable. We know that colonoscopy is a safe method to evaluate the integrity of the primary anastomosis, and the aim of our study is to investigate the effect of additional intraoperative colonoscopy on the reduction of postoperative anastomotic leakage. Here you can see a picture above with an intact anastomotic leakage, and the other picture shows an anastomotic leakage which we can see right during the surgery with endoscopy. The clinical question is if the addition of intraoperative colonoscopy reduces the risk of postoperative leakage. The population is patients with left-sided colorectal cancer after curable surgery, again with primary anastomosis. And we compare the patients with air leak test with intraoperative colonoscopy with the patients with air leak test alone. And the main outcome is the incidence of postoperative anastomotic leakage. The hypothesis is that the addition of intraoperative colonoscopy reduces the risk of postoperative leakage compared to air leak test alone. The clinical and research implication is to reduce the risk of anastomotic leakage in colorectal cancer surgery. So as a summary, we plan to finish our first project in May this year and to finish our second project in September 2024. I would like to finish my presentation with the words of Béla Hamvas: "Truth can be found by chance, but no one can be true by chance." Thank you for your attention.
Thank you, Ági, for your great presentation. Until we can expect the questions, I have one question. Does these studies report what kind of surgery are they undergoing? Because as far as I know, the TME can be done in at least 3 different ways. And what do you think? Can choosing the operation type, can it affect your result?
Yes, it's a very important question. Thank you for that. So the studies report about the types of the surgery, and we hope to get results of it by conducting a subgroup analysis. And we think that it's a different between the kind of surgeries, and also that it's a very important thing if the patients get a stoma after the surgery or not. So it's a very different population of the patients.
Thank you.
Can I just ask, do you have data on the cancer stage of the leaking and non-leaking patients separately?
Yes, fortunately we have almost in every article data of the different stages. So we investigate stage 1 to 3 patients, and we always have tables and graphs and Kaplan-Meier curves of the different stages.
Because to me, it would be quite reasonable to think that if you have got a big cancer, it's more difficult to operate on it, and there will be more leak. And so therefore I would think whoever leaks belongs to a population of the cancer population who are at a more advanced stage of cancer. And eventually, leak is just an indicator of a more advanced and therefore a worse prognosis subgroup of cancer patients. And therefore I would suggest that you come up with some data in your analysis proving that the leak and non-leak population are comparable in terms of cancer stage.
Yes, so we plan to have these data for sure, and I think that's why it's a very important topic, my second topic, because it has a big role in preventing postoperative leakage.
Do you have any data on the quality of the stapler used for the anastomosis?
Yes, we have, and we have a lot of studies including this, but this meta-analysis doesn't really focus on that. So we have the data, but we will see if we will have the time for processing these data.
Okay,
as
because
well.
I have a feeling that the quality of the stapler can affect the leak as well.
Yes, maybe it can be my third project.
Yeah, that's good. My other question is, what do you use for inflation for the second part of your study? When you use the endoscopy during the operation to check the leak?
I think it's not unified. So in the studies, I have to check all the data of it, but I'm not sure if it's unified.
Do you have the feeling that the increased pressure inside the bowel can increase the risk of leakage?
Yes, I have the feeling, and I think I'm not alone with it. But there are several studies, and I think also a meta-analysis, which showed that it doesn't have any more danger in it. So it's scientific evidence for it that it's as safe as air leak test alone.
Congrats on your presentation, and I would like to ask about the actual practice in Hungary regarding this intraoperative colonoscopy. Do you actually use it in your ward?
Yes, actually there are 3 types of institutions regarding this. The first one is where they don't use it at all. The second one is where they use it routinely, so after every rectal cancer surgery with anastomosis. And the third group is where they use it only if it's some question regarding the safety of the anastomosis. And I think it's all clear that if the surgeon thinks it's maybe questionable that it's safe, or if they need to prepare a stoma, then they have a quick look and they can decide.
Okay. So I'm trying again the questioning. So I can see that you have on the first topic one result that is quite the opposite as the others. And what do you think, what is the reason?
Yes, we have this one study as a black sheep. First of all, this study showed that this is not an opposite result, but that there is no statistically significant difference between the 2 groups. So it's the result, and they also thought that maybe it's because of the stage. They investigated 400 patients, and almost half of the patients were stage 3 colorectal cancer patients. And they found that investigating only stage 3 patients, they didn't find any difference neither. So maybe it's the quality of the surgery as they write it in the conclusion. I don't know the exact answer.